When it comes to endocrine disorders, diabetes mellitus, kind of the big guy. Yeah, but there's lots of other little endocrine disorders too. So it is helpful to go through both pituitary problems as well as target endocrine orders as well. I always tell people to try to remember the normal hormones that the pituitary and hypothalamus help produce, the pituitary being kind of the master gland. I'm not sure what mnemonic you used. An A&P flag pet is the one that I have used. But you probably got a cool one as well. Whichever works, let's go with it. Hypopituitarism isn't necessarily a disease, it's a description of a person incapable of producing physiologically sound amounts of pituitary hormones. A patient with hypopituitarism may have low production of follicle-stimulating hormone, luteinizing hormone, adrenocorticotropic hormone, growth hormone, prolactin, endorphins, thyroid-stimulating hormone. But if you have a patient with hypopituitarism, you have to think, why? What's going on here? Because that's what leads you to kind of the basic pathology. Oftentimes in this area of the pituitary, benign adenomas are to blame. A benign growth of pituitary tissue, and as the growth gets bigger, it actually squishes or crowds out normal cells and their ability to function and produce hormones. The interesting thing about the benign adenoma problem is that the benign adenomas generally occur in one of two types. Benign adenomas that produce their own hormones themselves, and benign adenomas that do not. In benign adenomas that produce their own hormone, what you can get is an excess of that particular hormone, while others can be relatively suppressed. In benign adenomas that do not produce functional excess hormone, simple hypopituitarism can be the result. Other things that may cause your patients to present with hypopituitarism, perhaps a brain surgery complication. Remember, the hypothalamus and the pituitary are at the base of the brain. Maybe something got nicked in there. Radiation to the brain, say for cancer, metastatic cancer to the brain, trauma, an accident, motor vehicle accident, tissue ischemia leading to infarction of that area of the base of the brain. Regardless, hypopituitarism and the low production of hormones has numerous clinical consequences. Reduction of TSH can lead to hypothyroidism. Reduction of FSH or LH can result in amenorrhea. Reduction in growth hormone can result in muscle atrophy. ACTH, adrenal insufficiency. So I just want to be clear, hypopituitarism is not a disease unto itself. It's a clinical presentation. That presentation needs a diagnostic workup to get basically a report regarding what hormones are produced, which ones are not, which ones are high, which ones are low, and then typically imaging or some other testing needs to be done to figure out what's going on with the pituitary. Is there a space-occupying lesion causing mass effect within the pituitary compartment? Treatment for hypopituitarism simply involves replacement of whatever hormones the person is deficient in. If there's a benign adenoma, there's a simple procedure, well, not so simple, called a hypophysectomy. And the picture's there, yes, you go in through the nose to access the pituitary vault and surgically remove the benign adenoma. Now, one example of a clinical scenario where a benign adenoma is a hormone-producing benign adenoma is acromegaly. The other name for acromegaly is gigantism. And this is a situation where the benign adenoma in the anterior pituitary produces an excess amount of growth hormone. Now, puberty is a boundary in this disease. When I was a kid, there was a very popular wrestler named Andre the Giant. And Andre the Giant was, I believe, 7'4". He definitely was a giant. In his early to middle adulthood, he was finally given the physiologic reason for his gigantism, and that was because he had a benign adenoma that secreted growth hormone. So Andre the Giant was exposed to an excess amount of growth hormone basically all his life. In patients who develop a benign adenoma that produces growth hormone after closure of the epiphyseal plates and the long bones can no longer grow, they are just subject to growth hormone effects that do not instill gigantism. That manifestation is called acromegaly. That produces enlargement of the hands, the feet, typically the jaw, but not the long bones. People do not gain height if they develop growth hormone excess after puberty. Generally speaking, your basic clinical picture for acromegaly is somebody kind of in their middle adulthood years who slowly, over the course of many years, starts to take on kind of hand-foot changes, shoes don't fit as well, and facial features change slowly over time. Now, you wouldn't think that enlargement of the hands or feet or the jaw or the brow line are all that big a deal, but growth hormone effects can be seen elsewhere in the body as well, most notably on the heart, and cardiomegaly is a problem for people with this condition. One of the presenting signs for acromegaly, which I always thought was very interesting, is visual alteration. Because of where the pituitary gland sits in the head, it is very close to the optic chiasm. And a benign adenoma, growth in that area, can actually cause pressure, depending on which way it's growing, on the optic chiasm that can cause very interesting visual changes. Hemianopia is the loss of vision on the same side of both eyes. These patients may also be diagnosed with hyperglycemia and or potentially diabetes because of the effects of growth hormone on their body. When growth hormone is secreted, the secondary effect is to spike blood sugar, because if you're going to tell your cells to grow, there darn well better be some glucose to help them do that. In my opinion, learning about syndrome of inappropriate antidiuretic hormone, SIADH, and diabetes insipidus, its opposite, should occur simultaneously. I don't think it should be one after another. I think we should talk about them at the same time. SIADH and DI are disorders of antidiuretic hormone. In one, you have too much, and in the other, not enough. So the first question you should ask yourself is, okay, well, how do I get either too much ADH or not enough ADH? SIADH, interestingly enough, is most commonly found in patients with lung cancer who have a certain subtype of lung cancer that produces its own antidiuretic hormone. I'd be willing to bet you right now, in your clinical practice, the most common times that you're going to come across SIADH is in patients that have lung cancer. It's not the only way, though. Benign adenomas that produce ADH in the pituitary can occur as well. Now, diabetes insipidus has kind of a two-pronged approach to its pathology. There could either be destruction of those cells within the pituitary. Maybe it's a case of hypopituitarism. Maybe it's the case of a benign tumor causing destruction of normal tissue, but loss of the ability to make ADH in the anterior pituitary. But there's another way. In some patients, with kidney disease, the kidneys and the nephron becomes insensitive to antidiuretic hormone, and water is lost. One of the most important things to remember here is antidiuretic hormone and its function. It retains water. So think about this reasonably. So a patient with SIADH is going to have too much of it and is going to retain a ton of water, fluid volume excess. The opposite happens in diabetes insipidus. They're not making ADH, or their kidneys aren't sensitive to it. They're just going to pee like crazy, and they're going to be dehydrated. In SIADH, excess fluid within the vasculature can cause dilutional hyponatremia. Salt level falls. In addition to that, if you're retaining fluid, you're not peeing it out. Oliguria is the clinical term for a small amount of urine output. And that urine output is going to be very concentrated. In addition, if the hyponatremia gets too low, there may be the potential for seizure development. In diabetes insipidus, as the dehydration continues and there's less water within the vasculature, this causes sodium levels to rise. These people are peeing out tons of very dilute urine, tons of it. They're dehydrating. They're throwing their salt levels off, and in so doing, they too are at risk for the development of seizures. So the diagnostic workup for both of these conditions is fairly straightforward. You check the osmolarity, also known as the concentration of blood and urine. In addition to that, to corroborate your osmolarity report, you'll also have these patients check urine-specific gravity, and all that is a fancy way to tell how much solute is in a person's urine. Patient with SIADH who's retaining water is going to have very concentrated urine with a high percentage or a high amount of solute in it. Their specific gravity for urine will be high. A person with diabetes insipidus who's peeing out a ton of very dilute urine will have very few solute particles in there. Their specific gravity of urine will be low. If you're working in clinics that test for these things, the most basic tests are actually the most intuitive too. In a patient with SIADH, if you're suspecting that, you make them drink water. It's called the water load test, and it makes total sense. If they don't have SIADH, as they're drinking a bunch of water, they should start peeing more. Patients with SIADH wouldn't do that. It's the same idea, but the opposite for diabetes insipidus. Patient comes in and is peeing all this dilute urine, deprive them of water, and watch what happens over time. If a non-DI patient is deprived of water, urine production slows down, right? In a patient with DI, that doesn't happen. Treatments for these conditions are, as you can imagine, also opposites as well. In SIADH, a very easy treatment is fluid restriction. And when I was back in clinical practice working with lung cancer patients all the time, 500 mLs of fluids a day was a common fluid restriction requirement for my SIADH patients. Salt liberalization. And in addition to that, medications that suppress the release of ADH. Now, a diabetes insipidus patient is dehydrated, so you need to replace fluids either orally or through an IV. Since these people don't have ADH, they can take a synthetic form of it. One common version and name is called DDAVP. I won't spell that out, just there as an example. What about those patients with DI who have kidneys that are insensitive to the effects of ADH? There are medications that can increase kidney sensitivity to antidiabetes.